Well, hello everyone. So, since we had the in-service training on the IV pumps, I've had some people come to me and say they're not very comfortable with norepinephrine. So, I wanted to put together a quick no thrills guide to mixing, starting norepinephrine, and hopefully, you'll be a little more comfortable and confident in giving norepinephrine because historically, Levophed or norepinephrine was referred to as Levophed, leave 'em dead. All right. And now, surprisingly, it is the first line vasopressor in virtually all situations. So I want you to be able to sleep like a baby at night knowing that you can give norepinephrine. So what's different between Levophed and Epi? And some of you might be thinking, well, I just got comfortable with push dose epinephrine, with mixing up an epinephrine drip, and now you've gone and complicated everything. So why norepinephrine as opposed to epinephrine? And I do want to clarify that we're not getting rid of push dose epinephrine or even epinephrine drips, because there are times when epinephrine's more appropriate and there are times when norepinephrine's more appropriate. And the protocol is written to give you all that clinical autonomy. You can look at the patient sitting in front of you and know whether they need a norepi or epi. So, this is something that we should know out of paramedic school, right? We should have a very thorough understanding of the different vasopressors and the physiological effects that they exert. But unfortunately, I guess that's not the case. So what can a norepinephrine be used for? Well, a better question might be, what can it not be used for? So epinephrine is first line in distributive shock. So sepsis, it is considered the first line vasopressor in septic shock. It is also first line in cardiogenic shock, surprisingly. And then it's first line in neurogenic shock. Does that mean you're going to give it for all of these every time? Mostly, that's mostly what it means. So, first line in sepsis means that generally, the majority of the time we should be given norepi for septic shock. The same holds true for cardiogenic shock as well. Now, there are different types of distributive shock. So if we're talking about anaphylaxis, well, I would not give norepinephrine first line in anaphylactic shock. So a general rule of thumb is I'm going to give norepi first in distributive shock, specifically sepsis, cardiogenic shock, and neurogenic shock. Now, there might be some caveats to that. If they are pediatrics, a lot of places they prefer epinephrine, but that's not always the case. Many pediatric ICUs or neonatal ICUs go to norepinephrine. If my patient's bradycardic, since norepi doesn't affect the heart rate as much as epinephrine, then I'm going to use epinephrine for bradycardia. In fact, if we're following the ACLS guidelines, well, norepinephrine is not listed for unstable bradycardia. Now, what you might find interesting is that the 2020 guidelines updated and said that a chemical means of increasing the heart rate for unstable bradycardia is as effective or as recommended. It has the same grade of recommendation as transcutaneous pacing. So we're not going to, if a patient is crashing on you, if they're severely bradycardic and hemodynamically unstable, well, norepi is probably not the best choice there. It is, like I said, first line in cardiogenic, distributive. and all forms of distributive shock with the exception of anaphylactic shock. And of course, if they're hypovolemic, well, we're going to, try to control the source of the hemorrhage, and we're going to replenish the volume. And of course, obstructive, it's generally not indicated. Vasopressors are generally not indicated in obstructive shock. So this will give you a roadmap for when am I going to give norepi. Now, notice that in cardiogenic shock, epinephrine is second line. It is second line. Why would we want to administer norepi and epi concurrently? Well, it's because of the properties of the specific vasopressors. So both epi and norepi are potent vasoconstrictors. They are potent vasoconstrictors. However, epinephrine affects contractility more, so the strength of contractions. So if you have a patient in cardiogenic shock, it is typical to start them on norepinephrine, and then if the cardiac output is insufficient, if they're not responding well to norepinephrine, then you add on epinephrine for more contractility. Okay. Now there are other vasopressors like dobutamine or milrinone that are typically preferred for cardiogenic shock because you get vasodilation, okay, with increased contractility that helps your cardiac output. Now, norepi does affect contractility as well. Norepinephrine does affect the strength of contractions as well, which is good because if we had a pure vasoconstrictor, we would increase the afterload. So basically imagine just a regular mechanical pump pumping against a lot of resistance. The flow is going to go down, all right? But if you have no resistance on the output side, then there's going to be more flow. So think of a water hose. If you turn on your water hose and you cap the end, well, nothing gets out. But if you remove that resistance, then it can come out. So the good thing about norepi is when we administer norepi, and it provides that alpha-1 vasoconstriction, it also increases the strength of contractions, but to a somewhat lesser degree than epinephrine. So if you need extra contractility, all right, then you can add epinephrine. Now, norepi does not affect the heart rate as much as epinephrine. Norepinephrine does not affect the heart rate as much. So you can see here that when it comes to heart rate and contractility, epinephrine has it beat. So if we're looking for more of a pure vasopressor effect, so imagine the patient has widespread vasodilation. Well, sepsis typically is more of an issue with just this volume that's kind of floating around, if you will, right, sitting in the vessels, right, that are dilated. And we turn this unstressed volume, so there's no stress on these vessels. We turn this unstressed volume into stressed volume. And we can increase preload simply by affecting the vasculature with norepinephrine. All right? So again, if I have a patient that's in septic shock or any of those other forms of shocks that we talked about, but the heart rate's really low, then I'm going to give epinephrine as opposed to norepinephrine because epinephrine affects the heart rate more. So I'm treating bradycardia with epinephrine. I'm treating, most forms of shock without severe bradycardia with norepinephrine. Now, once we get this going, how often do you titrate it? Well, it's pretty simple, about every 5 minutes, every 3 to 5 minutes. And we titrate this much like we do any other medication. But with most other medications, we're used to giving a certain set rate as opposed to a weight-based dose. So, you might be familiar with epi in terms of mics per minute. So let's say we start an epi drip off at 2 mics per minute. Well, that's easy to conceptualize because you know how much you're given. You might be more comfortable increasing it that way, right? Go from 2 mics per minute to 4 mics per minute as opposed to 0.02 mics per kg per minute to 0.04 mics per kg per minute. What's really the same thing, right? Instead of just increasing a flat mics per minute, now you're increasing mics per kg per minute, right? Except you're using smaller numbers, but you can increase the actual mics per minute, right, the same way simply by giving a little bit more mics per kg per minute. So when do we initiate this? Well, when would you initiate any other pressor? And that's what this boils down to. It's a new vasopressor, right? It's something you've never initiated, most likely. And now we're saying, here it is, use it. When do we use it? Well, when would you use pretty much any other form of vasopressors? Okay? So think of the majority of cases that you would say this patient needs to be on an epidrip or a dopamine drip if you're comfortable with dopamine, and apply that to norepi, except in the cases in the previous examples where I mentioned that it would be preferred to use epinephrine. So when do we initiate a vasopressor? Well, we do it to reverse shock and increase blood flow to the brain and the heart. But that's a little bit easier said than done. We have a pretty high threshold to start patients on vasopressors, which probably should not be the case. Now, I'm going to refer you back to our vasopressor training that we did months ago. And if you're still confused on when to initiate a vasopressor, go back and watch that training. But essentially, our goal is to maintain the blood pressure of a MAP greater than 65. We can also titrate or initiate it based on their mental status. So if their MAP's hovering somewhere around 65, but they're awake, alert, and oriented, then I might not be as quick to jump on the vasopressor train, okay? But if their MAP is hovering around 65, but they're altered, they're confused, their end-tidal is low, their knees are cold, their skin is cool and clammy, their capillary refill is prolonged, well then yes, I'm going to be, that's going to tip the scales quickly in favor of starting norepinephrine. You can also use end-tidal CO2. End-tidal CO2 is a marker of perfusion, right? So it doesn't just measure the CO2 concentration in the blood, it also measures perfusion of blood to the lungs. That's why when you're doing CPR and you have that big increase in end-tidal CO2, you think you have ROSC, or you suspect that you might have ROSC because you had that surge of that cardiac output increase because the heart started beating on its own. Now you can also use urine output and a capillary refill time. So low urine output and or a long capillary refill time. So use your physical exam to help guide and determine if you're going to initiate a vasopressor. Now, are we going to give fluid first? Well, of course. Unless this patient is actively decompensating right in front of me, I'm going to give some fluid first. What's our protocol for giving fluid? 250 ml aliquots. So I'm going to give these under pressure rapidly. as fast as I can, and I'm going to look for improvement. Are they improving with the fluid? If they are improving with the fluid, then I'm going to give a little bit more. All right. If they're not, then why keep giving the fluid? Because there are a lot of times where we give tons of fluid, knowing that about at least 1/3, possibly more of that fluid actually extravasates and goes into the interstitial space. All right. So, but if the fluid's working, I'm going to keep giving it. And you know what I can do? I can give these little boluses of fluid. I can look for increases in mental status. I can look for an increase in end-tidal CO2, which would demonstrate that this fluid is improving. It's actually improving blood flow to the lungs, and then therefore theoretically the rest of the body. I can look for improvements in mental status. I can look for a decrease in capillary refill. We can't pick one single thing to help us determine if the IV fluid bolus is working. Now, traditionally, we were fearful of starting vasopressors in the field, and essentially only did it if the patient was literally dying, and by that point, it was usually too late. Now we've learned from our mistakes, and we realize that fluid in massive volumes can be harmful. And we've also learned that early vasopressor administration does save lives, especially in septic shock. Okay? We're just not comfortable giving it. But if we think about sublingual nitro, we're comfortable giving that. And we're giving 400 micrograms of nitro at once sublingually. Here, we have the opportunity, if we start a vasopressor, to go low and see how the patient responds. To me, this is probably safer than giving large doses of nitro. Although giving large doses of nitro is actually extremely safe if they're not already hypotensive, but you get the point. So I'm also going to want to ask, if I'm doing an interfacility transfer frequently, some ERs may be of the mindset that they need 5-6 liters of fluid. And I really can't think of a situation in which that might be the case. I'm sure there could be, but are they already fluid overloaded? Has the hospital been giving fluid, and has it been working? If it hasn't been working, even though it's an interfacility transfer, maybe I'll consult the senior physician, say, Doc, they've had 3 liters of fluid. The blood pressure has not trended upward, so I don't think the fluid is effective. Can we go ahead and start them on Norepi? Are they in cardiogenic shock? If they're in cardiogenic shock, well, I might try a little bit of fluid, but with the understanding that it is, not likely to work if they have rails. If they have rails, fluid in their lungs, and their blood pressure is low, then that's typically considered cardiogenic shock. And if I gave my little fluid challenge, did the blood pressure improve? Now, just because we have Norepi doesn't mean that we're finished with epinephrine. Okay, there is still a role for epinephrine. And frequently, epinephrine can be used as a bridge to setting up a norepinephrine drip, the same way you would use push-dose epi to bridge to an epi drip currently. So if I have a patient, let's say it's a post-arrest patient, I go ahead and I pre-mix up my push-dose epi, and I notice that the heart rate is trending down, the blood pressure is trending down. I would give a bump, 10 to 20 mics of push-dose epi, and then set up my norepinephrine drip. So how do we mix it? Well, mixing it's pretty simple. You have 4 milligram vials. All right. You put the 4 milligrams in 250. You put the 4 milligrams in 250 mLs, and your concentration should work out to 16 mics per ml. Now, should we remove, I think it's 4 milligrams in 4 ml vials. Should we remove 4 mLs from the bag? Probably if we want a very precise drip. Because remember, we're giving a very concentrated pressor. When you're mixing a a dirty, quote, dirty epidrip, you're accustomed to having it in 1 mic per ml concentration. Now we have 16 mics per ml. That's very concentrated. So it is important to be precise here. Now, how do we administer that? At what rate do we administer it? Well, we administer it at 0.02 to 0.4 mics per kg per minute. 0.02 to 0.4 mics per kg per minute. How do you titrate? Well, you titrate frequently, all right? Every 3 to 5 minutes. So we go up from 0.02 mics per minute, and then we could go to 0.04 or 0.06, right? Or 0.08 or 0.10, 0.20. Quickly, we're going to get up to that 0.4 mics per kg per minute. And I hope that makes sense. Instead of starting off at 2 mics per minute, now we could still be, if they were 100 kgs and we started them off at 0.02 mics per kg per minute, how many mics per minute would they be getting? Well, they'd be getting, I believe, 2 mics per minute. And you don't necessarily need to know that, because now instead of just saying I'm going to start off at this many mics per minute, instead of doing that, I'm starting off at mics per kg per minute. Epinephrine is the same. How do we mix epinephrine drips? When using epinephrine on an IV pump, well, we put 4 milligrams in 250. Concentration is the same. The dose is nearly the same. Instead of 0.02 to 0.4 mics per kg per minute, we're giving 0.02 to 0.2 mics per kg per minute. And of course, we're going to titrate. And I hope that this all makes sense. And if it doesn't make sense, who should you reach out and talk to and say, I don't fully understand this? Well, me, right? Give me a phone call, send me an email, shoot me a text. Let's talk about it. We'll go over some scenarios until it makes sense. I want you to be comfortable with this, right? But there's honestly almost no reason not to be comfortable with it, because we're comfortable giving nitroglycerin. We're comfortable with push-dose epinephrine. This is the same thing, almost. Mixing it up is a little different. The concentration's different. But essentially, the triggers, when to do it, and how to titrate is basically the same. So if y'all ever have any questions, let me know.